talking about the movement for humanization of childbirth in Brazil, and also how the idea of evidence-based care, safe, effective care, and having care guidelines and protocols have been parallels movements in Brazil. And I'm very excited because I think that all your research subjects are can have a dialogue with this subject. So this is a picture to start about the women's movement in Brazil for birth centers, This is a demonstration of them. It's a bit messy, but it humanization, in the middle. And there are several of their demands here. So we have this demonstration of pregnant women, some of them very pregnant. This picture here is from one of the birth rallies that were in the late 70s and early 80s in UK. They were very important to shape the situation that they had in UK by that time. I will tell a bit about the history that's in a book called The Episiotomy, Challenging Obstetric Intervention. That's written by Ian Graham. He's a sociologist of knowledge. He's in the Institute for Health Innovation in Canada. And this is his PhD thesis, and he tells this very interesting story about how street demonstrations by women's movement in UK in the end of the 70s, in the early 80s, started a whole movement within the national health system in UK to change the practice. The whole movement and the conferences that were a result of this were called Changing Childbirth, the whole process called Change Childbirth. And this first thing happened because several incidents within hospitals made women get organized against them. One was that people were starting to fight against physical immobilization during childbirth. And some women demanded freedom for position during delivery. And some women who are, I'm thinking right now, the interconnection that Indian culture has on this, because they were basically people organized in yoga antenatal class. So just to figure out the influence that India has in the rest of the world. So many yoga teachers, there are pregnant women like yoga. You can find yoga for pregnant women everywhere because yoga is very popular for pregnant women. So they were rescuing yoga positions, and how they could help during delivery. And many women felt that they felt comfortable in other positions, like squatting position, upright positions, all four positions, etc. And so a woman was trying to deliver, and she felt better. She felt less pain, but in a non-conventional position. And she was physically forced into the lithotomic position. Because the doctor said in her hospital, no woman would deliver as an animal. So you can see in the placard, people say, "Squat for your rights." For the woman to have the rights to not be physically immobilized during childbirth. This had an incredible impact. I'll tell you more about the impacts that this kind of rallies had. But they immediately, these rallies, it was so interesting. This book calls it, it says that there was a very important medical anthropologist called Sheila Kissinger. I don't know if you heard of her. She wrote about 50 books on childbirth and culture and so on, and she was part of the birth of the Cochrane collaboration. She was very influential in the consumer group of the Cochrane collaboration, And they organized a demonstration. They put 10,000 women in front of the hospital where this, and the director had to resign, and they changed the guidelines in 1 week. So this is just to show how this can be powerful. So a brief history. That's what I'm telling you is in the end of the 70s. But in the 5th, in both sides of Atlantic, in the US and in UK, first in the US and afterwards in the UK, there were created associations against the cruelty to pregnant women. These associations were based on the legislations against cruelty against animals, because there were no kind of law that could help on that. So I'll show you something. You see this? This is a kind of fence. You know what I think? Even the hospital, we do not think like this. The baby was born heavily sedated, you know? So there were, the infant mortality was very high in this upper middle class people, because first only elite women would access this kind of care. This is very interesting because in countries that they had a proper epidemiological surveillance for maternal and child care, they this never thrived, you know, this kind of care. But where they didn't have, for instance, in the case of UK, they never let this be widespread practice, you know, because they could count the level of harm both for babies and children and mothers. So one of this was women's narratives, but also epidemiological surveillance of these outcomes was very important to change this model of care. But this model of care, with modification, it continued without heavy sedation and without women being put unconscious. But elite women tended to have this kind of birth in the 40s and 50s and in the 60s. This is a picture of a woman with a, you know, women used to deliver handcuffs. Why handcuffs? What do you think? Why handcuffed? Handcuffed, right? Okay. Yeah, not only for the, yeah, but because women could, you know, contaminate the surgical field, you know, so for their movement. So they used to be. Today we look at this and we think, this is barbaric, we think, isn't it? Do you have women being physically mobilized here in India during childbirth? Restrained, yeah. Yes. Do you have this? In Brazil, we can't find this yet. Still find it. Which restraint? Yes, yes. And sometimes it's not with a handcuff, right? It's, for instance, frequently you are immobilized because you have a drip or something. Yeah. So there's a whole movement in Brazil that people say, crucify it for birth, you know, because people get like this. And this is very interesting because the new narratives about birth physiology, they are extremely interesting because what they describe about physiology is that the descent of the baby in the pelvis is like taking a ring from your finger. You know, you have to make movement. If you just pull, you're gonna, you know, hurt yourself. You have to make this movement where you adjust the diameters of the heavy parts. You know, that's the reason why women need to change the movements. You know, to adapt the parts of the baby. So if you are physically mobilized, you don't have this resource. So this is one of the reasons that many people call this human rights violation, but we can call this a very anti-physiological position that have brings many limitations for birth progress. So in the 70s, there were many movements related to this, and one of you had this natural childbirth movement from the 70s. We had this birth without fear. We have the very many movements that were related to providers, to several authors that were like Le Boyer, like Passionnick, and Dick Reed. Several authors were proposing new forms of having birth. And we also have very strong influence of the hippie movement. The hippie movement started. If you read the hippie movement's manual for childbirth, like, for instance, Ina May Guide to, have you ever heard of Ina May? Who here have Ina May Gaskin? Ina May Gaskin was I think that we can say she is a hippie, and she was one of the founders of the a hippie community called The Farm. So they started in a very intuitive way, thinking about home birth and so on, without proper knowledge of this. But they found many partners who helped them. So they kept epidemiological data of everything of their birth, So they have a very interesting file, and they started building on this. She even invented a very interesting maneuver for shoulder dystocia, that's called Gaskin maneuver, They became a whole school of midwifery, and afterward they built the whole school of midwifery, but starting for the hippie movement. So they put together the very hippie style of thinking with the best of scientific evidence. It's a very interesting movement that they had. And also, like I told you yesterday, there was this Boston Women's Health Book Collective. I know you're having an exam these days. Did anyone have the chance to Google the Boston Women's Health Book Collective? You should. It's amazingly interesting. And the Boston Women's Health Book Collective had a very important role in the dissemination of Cochrane initiatives and the guides and protocols that we have. So in Brazil, at the same time, we had all these influences. And also there were some epidemiological research on childbirth by that time that were putting together mixed method research using heavy, hard epidemiological data, the perinatal epidemiology, conventional one, with qualitative research. And one of them is the Dossier Caxias, which is very interesting. It's an extensive report of women's experience of childbirth. There was also a research about quality of care in Sao Paulo called Violence, a Look at the City, which is very important to bring this issue. In the 90s, a movement was created called the Network for the Humanization of Childbirth. This movement was built from several different social actors. You had perinatal epidemiologists, you had alternative providers like yoga teachers and so on. We had health managers, lots of people working with organizing services, many doctors, nurses, etc., women's movement, feminist movements, that was everything put together. And so that was this network of the humanization of childbirth. And by that time, people were already talking about violence in childbirth. But people decided that talking about humanization was a more diplomatic term to talk about this issue. But there were also in the 90s some initiatives from the public health communities, for the human rights communities related to childbirth, very interesting ones. So I put you here to the Women in the Body, which is the name of the first edition of the Boston Women's Health Book Collective. So in the 90s, we have the evidence-based medicine movement. It started with the Oxford Perinatal Epidemiology Unit. It was a very interesting initiative, and it was very much inspired. In this first part of the session, I will talk about humanization. In the second one, I will tell more deeply the history of evidence-based care, the Cochrane collaboration, the other collaboration, the hierarchy of evidence. But by now, I would say that the Oxford Perinatal Epidemiology Unit was very much inspired by the fact that some of the people who were the founders had an experience in other countries where they had midwives, especially in poor countries where they have midwives. So they were very impressed by the fact that babies would be born with very little help, sometimes very healthy. And here I want to stress that for some women, medical care is absolutely necessary, and we need to have this care available. Sometimes surgical care, sometimes, intensive care is very important for having good maternal and child health indicators. But for most women, babies will be born without or despite the provider, and the problem is not that we have heavy technology. The problem is inappropriate use of it, because most women won't need this. So these people were very much inspired by the idea that they saw babies being born very healthy and well without having a medical doctor. And as you know, in UK, most women deliver not with doctors but with midwives. So because they have perinatal epidemiology, because they have since from the middle of the 19th century, they have regular data of maternal mortality and child mortality. They started to figure out when they started that wealthier women had the worst outcomes, because they had more intervention. So they invested very much in having midwives. It's not they don't have technology available. So in UK, presently they say every woman needs a midwife, and some women needs a midwife and a doctor. So it's more or less their idea. So the Oxford Perinatal Epidemiology Unit was organized to systematically review all the interventions in childbirth. So they mapped 275 different interventions, and they searched for anything published from 1950 on to systematically review and use what they call it by that time the hierarchy of evidence, because we were discussing this yesterday. Oh, can we call this evidence? I'll be back to this in the second part of the presentation. But the idea is that the standard, the gold standard of epidemiological research in terms of clinical intervention would be the so-called randomized controlled trial. We'll be back to this. So the Oxford Perinatal Epidemiology Unit was the embryo of the Cochrane collaboration, which is an international collaboration that makes evidence synthesis and dissemination. So from the beginning, the Cochrane collaboration had a very important consumers group. And in its start, all groups had consumer participation. This is very interesting because it was very novel in medicine to have consumers setting the research agenda. And this unit, the Oxford Perinatal Epidemiology Unit, who was the embryo of the Cochrane collaboration, developed the methodology of what we call presently systematic review. It was developed in this process. So by the 70s, the hegemonic model was hospitalization for everybody, complete sedation, routine forceps for primipara, episiotomy, these high rates of maternal and neonatal complications. So as the anthropologists of the collaboration used to say, there was gender bias in health research. So an example would be episiotomy. I'm bringing here, this is a good debate, right? In your left, there's some direct action by Brazilian Consumers Association to inform women about episiotomy, that women have the right to refuse it. And this is a very interesting photograph exhibit by a Brazilian photographer called Carla Reiter. She made these sets of pictures about women telling their stories or childbirth experience. It's very interesting. It's called 1 in 4. It's called 1 in 4 because we in Brazil had this first population-based survey on obstetric violence, and 1 in 4 women reported obstetric violence, including those who the medical establishment, saying that the onus of the proof, the onus of the evidence would be up to the doctors. So Sheila Kissinger and her colleagues wrote in this book, it's up to women to refuse consent to many interventions unless it proves necessary and to produce evidence to support these interventions. It's in the hands of the obstetrician who produced this surgical one to prove that their benefits outweigh their harm or stop this practice that is demonstrably damaging to many women and cause enormous and unnecessary suffering. I'm telling you, just to raise your curiosity in this person, that is Archie Cochrane, who was the one who names the collaboration. I don't know if you know much about him. He was a British clinical epidemiology, and he was an activist for the rights of patients. He was himself, he had more than one family illnesses, and he describes his experience as patient in a very interesting way. He was very concerned about the issue of safe and effective appropriate technology, but also inspiring compassion and kindness that he thought that was even more difficult. He said, we have to teach medical students, not only medical issues, but also sociology, anthropology, etc. But the key is how can we inspire compassion and kindness, which was very difficult. And he survived 2 wars. He wrote some papers about his experience in concentration camp. He was in concentration camp, and he was a fighter in the Spanish Civil War, and then in the Second War as a doctor. So he believes that he was very skeptical of medical technology, and he tells the reason why in these books, which are extremely interesting. This is an exhibit they did about his life, and you can read here in Spanish. Just to mention that evidence is a term that has different meanings depending on the context when it's used. It's very polysemic. It has different meanings. It has to be acknowledged because we have to understand why certain kinds of arguments are called evidence. So when most people, when evidence means Cochrane-like, this evidence has the potential to promote or to block social changes. And the idea is that evidence can be an argument to reduce the vulnerability of people and expand their rights. So that's a whole use for evidence as rights. I will give you the example of the case of hormonal therapy. It's very interesting. The whole story. These two to finish because it's 10 to 4, and I give you a little chance to speak as yesterday. So I love this cartoon because this summarizes very well the situation. So the guy says, this prescription will help you sleep unless you worry about cancer, heart disease, stroke, about blood clot, dementia, etc. Thank you.